Okay.
The only thing,
sorry, yes,
the only thing I want to add on that is a lot of decisions about how you actually use a vaccine you can't take till you've got it. For example, we take a lot of decisions around the flu vaccine about who gets it in which order, which priority groups will it have most impact on, and which people shouldn't have it, which of course you can't know till you know the exact effect of your vaccine. So there's quite a lot of decision making in there as well about, do you start with the most vulnerable, do you start with healthcare workers, who do you start with, that we won't be able to decide till later in the process. Unlike testing, and as the Secretary of State already hinted at, this is an area where we are very used to doing this at scale every year with the flu vaccine. And other vaccines, so we don't have the same. It's a very complex system, but there's much more precedent in the UK for how you scale up from the discovery to the implementation that we're building on for what we're doing with the Oxford vaccine.
Aaron? Thank you. If I could just talk about advice structures a bit more, go back to SAGE advice more generally. We heard from Sir Patrick last Thursday. He was very clear, obviously, that it's an advisory body. We've been the government rather, has been very clear throughout that it's been guided by the science. But obviously the science is still conditional on what can actually be delivered. So my question is, how have those cabinet committees you referred to, have they worked with SAGE? Because, it's been clear in the early stages that we didn't have a testing capacity, we didn't have the contact tracing capacity. Were those recommendations coming out of SAGE that we should be doing this, and someone was having to push back and say, but we can't? How did that work?
Well, there's two answers to that question. The first is that we were guided by the science, and the various SAGE conclusions, especially on the lockdown measures, the NPIs as we call them, non-pharmaceutical interventions, they were followed, and they were followed in a timely manner. Some cases on the same day. For instance, I know you had an exchange about what happened on the 16th of March, for instance, and if you look at the SAGE minutes from the morning of the 16th of March and my speech in the chamber in the evening of the 16th of March, we were following the recommendations from SAGE. But I always argue that we are guided by the science because you take into account the scientific evidence and then you also take into account everything else. The key feature of how that works is that SAGE is a body that advises the CMO and the CSA, and they in turn advise ministers. So whether that's through COBRA or through the COVID-0 structure that we have now, the advice from SAGE comes to us and comes to me as Health Secretary through the CMO and the scientific advice through the CSA. And they also take into account wider considerations in that advice, and then I take into account all considerations in the official policy advice that I get from the civil service, and that may sound like it's a number of layers, but it's really important. So SAGE is a group of scientists, and they support the CMO and CSA to come to their judgments on what scientific and medical advice they should give to ministers through, and whether that's the CMO walking into my office as Secretary of State, or whether it's a more formal advice from the CMO or CSA to the cabinet subcommittees.
Thank you. And it's been recently reported, I think 8th of July, that the Joint Biosecurity Council is now going to play a bigger role and SAGE will meet less often. Is this a recognition that we've moved from a period where it's been about the science to now where we're trying to balance more factors?
No, I think we've tried to balance all these factors all the way along. But SAGE, remember, is the scientific advisory group on emergencies. It's not a body that is just there for coronavirus or indeed for communicable diseases and epidemics and pandemics. And as we build our capability to deal with epidemics on a grand scale, we're building the capability together in one place under the JBC as the analytical function.
And is the advice, are the scientists on the JBC, are they going to be up for cross-examination in the way that members of SAGE have been through the earlier stages of the pandemic?
Well, the JBC is part of NHS Test and Trace, and that's one way to get analytical capability into the system in large numbers.
Thank you. And just on some of those points, when did COBRA last meet?
Well, I haven't got that date to hand.
They're quite important meetings. Do you remember them? Was it in the last couple of weeks?
I don't have the date to hand, I'm sorry.
Last month?
Well, the thing is that the decision making for coronavirus that's in place is that there's a COVID-O, which takes the operational decisions, meets 2 or 3 times a week, and then that reports into COVID-S, which takes the strategic decisions and is chaired by the Prime Minister, and that works effectively.
You described that SAGE is the scientific advisory group for emergencies. COBRA is the established means of operating the machinery of government during emergencies. It seems to me like an emergency. Why has COBRA... the fact that you can't remember a recent meeting suggests it hasn't met for some time.
But that's because the effective cross-government decision-making on coronavirus is taken either at COVID-O for operational matters or COVID-S for strategic matters.
But it used to be in COBRA, did it not?
Well, at the start of the crisis, as you'll know from being in government, when there's an emergency, you call a COBRA.
Yeah.
And I chaired COBRAs right from the start on this.
Until when? When did you stop?
I chaired 6 in January and February, and the Prime Minister took the chair from March onwards. And then a permanent coronavirus cabinet subcommittee system was put in place with COVID-S and COVID-O.
Was there a COBRA meeting to decide on the lockdown measures on the 16th of March?
Yes.
There was. Was there a COBRA meeting to decide on some of the releasing of the lockdown measures?
There were certainly cross-government decision-making meetings. Under what badge, I don't recall.
But specifically a COBRA meeting, because the machinery of government is important in handling crises, to make sure that the right people are represented. If SAGE is a creature of COBRA, it can only be instigated by COBRA, and its constitution requires it to operate within COBRA. So why would that established means of handling emergencies have been abandoned?
Because, well, I'm not sure I'd characterise it that way. What I'd say is that because of the scale of this emergency, dwarfing all others, we put in place a permanent cabinet committee structure to deal with cross-government decisions relating to coronavirus, on which the CMO and the CSA meet. You're absolutely right. It's very important the right people in the room for decisions, so any advice from my point of view as Health Secretary, whether you're in a Cabinet Office briefing room A, which is what COBRA stands for, or whether you're in any different room, what matters is, are the right people around the table with the right authority to make the decision? And replacing a system, the COBRA system is there to be able to stand up very quickly in response to unforeseen events. We changed the whole cabinet subcommittee structure in order to have a permanent standing subcommittee that could deal with coronavirus.
Secretary, it's more than about the room, as we both know. It's about the systems. You've just referred to it. It is sufficiently well established that, literally in terms of the constitution of SAGE can only be activated by COBRA. It can't be activated by a room. It can be activated by a process that's put in place to handle emergencies.
Yeah.
So why has that established process for handling emergencies been abandoned? And if it hasn't been abandoned, if that's not the right word, why has it not met for beyond which you can remember?
Look, what I've tried to explain is that from my point of view as Health Secretary, there are decisions that I could take within my area, and there are decisions that then needed to go up because they require cross-government execution, or they are so big, novel or contentious that they need cross-government approval. And for those purposes, a COBRA meeting can do that job because it is a formal decision-making body of government. And then COVID-O and COVID-S were set up to be able to do that job. Now, of course, SAGE's input into this was triggered by COBRA, as in by a COBRA meeting right at the start. And SAGE has been working on this ever since. But whether you use a COBRA as a standing facility that can be used for all emergencies, and then the fact of the matter is we then switch to essentially a bespoke system to deal with coronavirus. For a shorter, smaller emergency, you just wouldn't set up a cabinet subcommittee for these specific purposes.
I'll turn to Graham Stringer, but is the new COVID decision-making bodies, are they supported by the Civil Contingency Secretariat?
They're supported by their own secretariat.
Not by the Civil Contingency Secretariat?
As far as I'm aware, it's a Cabinet Office matter.
Which is the Civil Contingency Secretariat, is the standing machinery whose raison d'etre it is to respond to emergencies. And so moving away from COBRA, you moved away from that standing capability of handling emergencies.
Well, because we need a semi-permanent structure to deal with COVID decision-making. And the Civil Contingency Secretariat have to look right across the piece. So the Cabinet Office and the deciding to set up a bespoke decision-making body, cross-government decision-making body, supported by a secretariat for the purposes of this pandemic, meant that from my point of view as Health Secretary, I could go and get cross-government decisions taken if I needed to, and that's what was necessary. Can you think of
another emergency in which COBRA has been stood down before, not only before the emergency is over, but actually perhaps even in the early stages of the emergency?
Not in the no, I don't think that's right. Not in the early stages, and the point is that decision-making at COBRA was replaced by decision-making at an appropriate body that was properly constituted to take cross-government decisions. And that's what, as far as the effectiveness of government decision-making, that's what matters.
And so the new body is more effective than COBRA?
It does exactly the same job as from my point of view.
Then why change it? But anyway, Graham Stringer.
I'd like to follow on from some of the evidence that Sir Patrick Vallance gave us last Thursday, seems a long time ago now. The first one was he pointed us towards a paper that estimated the total number of deaths from COVID, not just by the virus itself, but by the closing down of part of the health service and the collapse of part of the economy. That paper that came out on the 8th of April, pointing towards 200,000 deaths, which were not caused by infection of the virus. How did you respond when you got that information? What was your policy response? Because it's a pretty awful piece of work.
So the advice that I'd received at the time, which I think was wise advice, is that there are a number of different problems that come with a very large epidemic or a pandemic. There's the direct deaths from COVID. There's the indirect deaths if the NHS is overwhelmed. Yeah. And thankfully we minimised that because at no point was the NHS overwhelmed. The third group is that deaths that, because you can't do certain treatments. So, for instance, there's certain cancer treatments, especially immunotherapy, that you can't do in the middle of a pandemic because people are more at risk of dying if they have the treatment than not. And then there's the deaths due to the economic consequences of the decisions that you're taking. And we always were alive to all four different types of mortality that could be a consequence of the disease, and including the decisions that you take in response to the disease. And Chris Whitty set these out in public at the time. The estimates of the numbers in each category are highly speculative, and the paper in question on the 8th of April includes in the footnote that the number connected to the to the numbers are estimates and don't take into account a government response on the economic side. So we always knew that the decisions you take to prevent deaths from COVID, of course, have other consequences. But and that is one of the balancing factors that you have to take into account. But nevertheless, the decisions we took were absolutely the right ones, because the deaths from COVID that were not just projected, but we could see the shape of the curve starting to happen, were much, much higher.
Right. I accept that as a qualitative description. I also accept that the figures are speculative. Nobody's ever done this kind of calculation exactly before. And the figures in the paper go from 1.25 million, I think, if the NHS was overwhelmed of deaths, down to relatively low figures. What I'm interested in is the policy response to intensive care being overwhelmed was clear.
Yeah.
I don't see any response, really, to the fact that a lot of people were going to die because some of the cancer services, some of the other regular services weren't going to be provided. At the moment in Greater Manchester, there are 25% of beds in hospitals that are vacant. For instance, people not being treated, they may well be dying because of that. And I haven't seen any response throughout this to that particular issue.
Oh, I see. Oh no, I think that's. I can certainly write you in full with the whole NHS restart plan, which has been now ongoing for many weeks. For instance, getting cancer referrals up has been a big part of the job, making sure that people come forward when they have you'll have heard me speak in the chamber about making sure that people come forward. We have a whole marketing campaign around help us to help you. So the restart of the NHS is all part of mitigating exactly that sort of mortality.
I accept things like cervical cancer testing has improved since the start of this process. But I'm really asking the question, what was your response to start with? You build extra capacity for intensive care outside of hospitals, you clear out intensive care, but the rest of the health service, which had consequence deaths, I didn't see you reacting very quickly to that.
Oh, I see. No, that was always in our mind and in our plan, to keep as much of that going as possible, considering that there's a pandemic on. If you think about it, we were... part of the reason for the Nightingales project, which was an extraordinary project, when I said at the end of March, we must build extra capacity. Middle of March, we must build extra capacity for this. We had the ventilator project ongoing at the same time, very effective. And the NHS, unbelievably, pulled off building the Nightingales in 9 days.
A success. I'm looking at the other side of the equation.
Yeah, I was going to come on to that. Because part of the design of the Nightingales was to be able to take intubated patients who were on ventilators out of intensive care units so that they could be used for everything else that the NHS has to do.
So are you happy that there is still capacity within our health service, considerable capacity, which isn't being used?
Well, I want to make sure that more people come forward. We're putting more money into diagnostics because where that's the bottleneck, and and all of the decisions on whether somebody is better off coming to hospital or not because COVID is about. They are clinical decisions, and increasingly now, because the NHS is increasingly split into what we call green and blue sites with and without COVID, we're getting that restart going.
Can I?
Yep.
So I don't want to take too much time, but the other thing that Sir Patrick told us, that originally the response to this epidemic was based on numbers coming out of China for how quickly the virus spread. It was also predicated really on the fact that we were 4 weeks behind Italy and some other European countries. Start of March, it became clear that the virus in Europe, and in this country in particular, was spreading twice as quickly, and that we were only a fortnight behind Italy in terms of the infection and the numbers of infection. Can you tell us how you responded to that awareness that the original scientific data, which quite recently was being worked on,
Yeah.
but was not appropriate for where we were at the start of March?
Yes, we took more decisions about more measures that we had to bring in, and we took those decisions sooner because that evidence came in, and the result of that was that we brought in many of the lockdown measures, which were brought in over a period. We brought them in earlier in the epidemiological curve than most other comparable countries.
You know where this question's leading, don't you? Because that data came in. Had you taken immediate decision to lock down or more extreme measures that eventually were taken on the 23rd of March, a lot of lives would have been saved. And I'm not trying to look through the rearview mirror, as I think you said in response to that question, but the information in terms of the spread of the infection and of where we were in relationship to Italy was available 11 or 12 days before the actual lockdown.
No, that's categorically not true. The decisions that we took responding to new scientific information were taken incredibly quickly, sometimes intraday. So if you take the 16th of March, for instance, on that day we received advice from SAGE advising that the virus was accelerating. And by that evening, I was in the chamber announcing that there should be no social contact unless absolutely necessary and no travel unless necessary. So in my 8 years in government, I've never seen faster decision-making on such big issues as happened then, translating scientific advice into government action with unbelievable urgency.
But the actual information, this will be my last point, the actual information, it wasn't so much that the virus was accelerating, it was that we'd got the estimates of how quickly it was spreading wrong to start with, because they were based on Chinese figures.
Yes.
That was available a week before the 16th of March.
Well,
that's a matter of fact.
The matter of fact is that we took advice the advice, that scientific advice, and we acted on it with unbelievable speed and urgency across all 4 nations, shoulder to shoulder with our colleagues in the Welsh government and the SNP government in Scotland and Northern Ireland. That was the speed of those decisions was incredibly fast. And as we've now published the SAGE evidence, you don't need to take that from me or from Sir Patrick. What you can do is read what SAGE advised and read what we did, and you will find that the gap from what we were advised to what we did was incredibly fast. And I know that to be true because I lived it. And seeing the speed and being part of the speed of those decision-making, that decision-making was extraordinary. And now, it is absolutely true that we continued to strengthen the lockdown through this period. The idea that lockdown is a date is wrong, because actually what matters epidemiologically is the behaviour of people, and you saw throughout this period people were going about their ordinary business less and less throughout the period.
Thank you.
If I may just
very briefly, Chris.
I do think, the two halves of your questioning demonstrate the dilemmas of policy making at the time. We were very clear that there is a big cost, not just economically, but in health terms, to lockdown, and at the same time, lockdown is the answer to some of the issues you are raising. And that balancing act, and Professor Whitty has spoken about this a lot, of when to time an intervention so that you minimise the damage that you pointed to in the first half of your questions and maximise the gain that you pointed to. That is exactly what was going on in government at that period. Now, as the Secretary of State said, I'm not going to say we got those balances exactly right and that we do it again knowing what we do now, but those are exactly the dilemmas that officials, ministers and scientists were wrestling with over that period.
Thank you, Chris. Let me turn to Chris Clarkson and then Zara Sultana and then Mark Logan. Chris.
Thank you, Chair. Secretary of State, I'd like to talk about testing numbers. So firstly, I'd like to ask you, how do you respond to the criticisms from the chairman of the UK Statistics Authority that when you were presenting numbers of tests, and I'm going to quote now, the aim seems to be to show the largest possible number of tests, even at the expense of understanding?
Yes. Look, I have an enormous amount of respect for the UK Stats Authority, and they do a very important job. The purpose of the target was to build a global scale testing capability. And of course, measurement of that and the stats we publish alongside has improved all the way through. But you know, as we were racing down the track and laying the track in front of us at the same time, building the measurement of that was going on alongside the building of this enormous capability. And so if you look at this down a purely stats angle, you might look and say, well, why did he come out with that 100,000 figure? But I wasn't looking at it down a pure measurement angle. I was specifically using this target to drive action. It was an action-oriented target. It was not a passive measurement of separately of what was happening. And so we had a way of measuring the system that we had, and I put the full weight of the government machine behind driving that up, because that is what the country needed at the time. And I take the brickbats from people who had a different point of view in the narrow sense of the UK Stats Authority, a perfectly legitimate point about the exactitudes of measurement and the normal very high standards we hold statistics to in this country, quite rightly. But when you're over a period of a few short weeks building a global diagnostics capability that is now bigger than almost anywhere in the world and started very, very, very small, worrying about a letter from the Stats Authority that might come through in a few weeks' time is not top of the in-tray.
Thank you. Chris, and if we could keep the answers short, then we can make sure we get through lots of questions. Chris.
Okay, yeah, I'll move on then. On the 6th of July, it was announced that the government would stop publishing the daily tally for people being tested for the virus. So what was the rationale behind that?
Oh, because the measure of people tested deduplicated somebody if they'd been tested at any point in previously. So if you were tested, say, in March and tested negative, and then tested in June, then the fact that you were tested in March meant that you wouldn't count in those figures when you were tested in June. And that was no longer a relevant fact, because if you'd been tested negative in March, it had no bearing on whether you need to know or not the result of your test in June. Because of the expansion of testing, it then became harder to do that deduplication. And within Pillars 1 and 2, we have got the deduplication up and running again. It's published on the website, but it isn't a material statistic in the management of the testing regime. It's a meaningless stat.
Thank you.
So how did that come about? Because presumably, if you were measuring the number of tests, the fact that one person's had more than one test surely wouldn't have been relevant.
No, it's not relevant. It does matter that somebody hasn't been tested by two different parts of the testing system in a very short period of time, say within a few days. And we do deduplicate for two tests that have been done on the same person within 7 days, because you don't want somebody to phone up and get a at-home test, for instance, post it off, but deteriorate, end up in hospital, be tested because they've gone into hospital because that is standard practice, and that counts as 2 positive cases. So you do need that deduplication in a short period of time. But you don't need it over the whole crisis. It's analogous to what we've discovered in the last week on deaths data, which is that at the start it was perfectly reasonable to say that if somebody had ever registered positive with COVID and died, they died from COVID. For the first few weeks of the crisis, and indeed in the peak, that was a perfectly reasonable thing to do. However, that is no longer reasonable, because if you had COVID in March and fully recovered, or even were asymptomatic, and now die of something completely different, then the way it was being measured until last week counted that as a death with COVID. That clearly is no longer appropriate, and PHE are currently reviewing that time series. So both of these were brought in at the start, perfectly reasonable shorthand for how to measure something that mattered then, but as time has gone on, they've become less and less relevant statistics.
Chris?
You just said that PHE England's determining that time series. Is there one in place already, or is this a moving aperture, as it were?
Well, they'll publish very, very shortly a revised methodology for how to get an accurate measure of deaths with COVID. As Professor Whitty has repeatedly said, the only true measure of the impact of this in terms of mortality is looking back at the total number of excess deaths compared to this period of time and time of year, because all the other measures involve different statistical techniques to work out if something is a death attributed to COVID or not, and to take into account Mr. Stringer's point correctly, there are deaths that are because of the pandemic that are not deaths from COVID. If you were in the middle of cancer treatment and that cancer treatment had to be stopped, even if that was the right clinical judgment because you were higher risk of going into hospital or continuing the treatment because COVID was about, and then died, that matters too. And so there's lots of different ways that different countries measure deaths data. And the Whitty doctrine is that you must look at the overall number of excess deaths afterwards, and that way you'll find out the overall impact.
Thank you. Chris?
One final question, Chair. No data is available for the total lab capacity for testing since the 7th of July. Why is that, and when will that data be available?
The lab capacity is as at the 7th of July, as far as I know, so it merely... I think it's because it merely hasn't been updated. That the capacity data is very important, and we continue to grow it.
Secretary, we write to the committee if the answer is different to that, your supposition. Thank you very much. Thank you, Chris. Zara Sultana, then Mark Logan, and then Dawn Butler.
The Prime Minister has described the huge amount of work that has been devoted to the possibility of a second wave. What measures and reserves have your department put in place?
Well, we've got an enormous work plan going on to prepare for the winter, essentially, and prepare for the future. We describe it as our battle plan. It involves, firstly, test and trace, the expansion of test and trace. The Prime Minister has committed to a capacity for 500,000 antigen tests by the end of October, another testing target that I'm delighted to accept. The expansion and support of the NHS, both expansion in terms of staff numbers. You'll have seen that there are 12,000 more nurses than this time last year, for instance, and further figures on NHS staffing come out on Thursday. We've expanded, we're keeping the Nightingale hospitals and we are keeping the capacity that we need within the independent sector, and we're expanding emergency care. In the support for social care, we've put in £3.8 billion into social care so far, and we continue to support social care. Supply of PPE and drugs, which is incredibly important, and where Lord Dighton has done an amazing job on PPE, meaning that we're now rebuilding our stockpiles. and doing so in a way that they'll be immediately accessible should demand for PPE go up, and then the supply of medicines. The fifth area is treatment and vaccines, of which there's been much discussion, especially in the last 48 hours. Some really good news coming through, although on vaccines that is all conditional because a vaccine may not work, and on treatments it's great that we've got dexamethasone through, and we hope to bring forward more successful treatments in short order. The sixth is protecting the vulnerable, so the shielding programme will be paused from the end of this month, but paused correctly, not stopped, because we will bring it back in if we need to, but for the time being from the end of this month it is safe for people who have been shielding to go out. And then the seventh is the non-pharmaceutical interventions, the lockdown measures, which at the moment are increasingly focused on local action rather than a national lockdown. But we, of course, don't rule out bringing in a further national lockdown if that is what is needed.
So is it fair to say that you've learnt lessons? You mentioned earlier that there have been lessons to be learned. So with what you're saying, would you say that you have learned the lessons in preparation for a second wave?
Yes, we've learned a huge amount of lessons in how we're preparing for the future as the sciences continue to improve and as we've learned from how we organise things.
I want to touch on a point where you said lockdown is not a date because the Prime Minister in a televised address on March the 22nd gave the British people a very simple instruction: you must stay at home. And you've, in Parliament, in the Chamber, said you came to the House on March the 16th and said all unnecessary social contact should cease. I think it's really important that we address the issue of dates, because what I fear is that you're taking part in historic revisionism, and it's really important that we have that sense of accountability. So do you stick by the fact either lockdown was on the 16th, or lockdown was on March the 23rd, or lockdown didn't happen, or it's not a date? Could you elaborate on that?
We've already discussed that in the last few questions. The point is there were a whole series of actions that were taken over that period to increase the number of interventions that made social distancing stronger and stronger. And the reason I raised the 16th is because it was reported from this committee, from what the Chief Scientific Advisor said last week, that the 16th was a date when SAGE called for lockdown. That is not the point I've been making is that SAGE made recommendations and we received scientific and medical advice from the CSA and CMO, which we followed on the 16th. Further recommendations were then made, which were followed very rapidly. Over that whole period, we saw the amount of social activity and interaction, which is what the virus thrives on, falling over the period.
If that's the case and all scientific advice was pointing towards a lockdown, why did the government allow 250,000 people to assemble in Cheltenham from March the 10th to March the 13th?
Well, the advice that we followed at the time was the best assessment of the scientific advice, taking into account all the other considerations. And that's why we made the decisions that we did based on scientific advice. And as I say, that they were implemented by not only the UK government, but also the Labour government in Wales, the SNP government in Scotland, at the same time, on the basis of the advice actually from the 4 CMOs, as well as, of course, the scientific advice.
I think you must appreciate how important this is, given the fact that an Ipso Mori poll had 69% of British public thinking that the original lockdown on March the 23rd was imposed too late, and this has been shared by Niall Ferguson, who told this committee on the 10th of June that if we had imposed a lockdown a week earlier, the death toll would have halved. So if you could go back in time, would you impose a lockdown earlier?
Well, I can't go back in time, but what I can do is learn the lessons that we need to learn. And what I can tell you with absolute certainty is that we made the decisions based on the information and the science that we had at the time, and we're constantly learning from that science.
I'm going to quickly just touch on a few more things and then I'll give way to others. So I just want to quickly touch on face masks, because there's 10 production lines being commissioned from a private firm in Coventry, as well as 14 million overall. Internationally, we've seen governments and local authorities and municipalities provide free reusable masks to the public, why aren't we doing the same, given the fact that this could be a considerable financial burden on so many people in this country?
Well, the budget for personal protective equipment this year, the government budget is £13.8 billion. It is a UK-wide endeavour, and we are working incredibly hard to deliver PPE to where it's most needed. Of course, we've increased the guidance and made mandatory the wearing of face masks and face coverings in certain circumstances, and that is, and then provided them in other circumstances where we think it's appropriate.
And just on the app, last month Norway's tracing app was suspended due to privacy concerns, and according to Amnesty International, it was one of the most invasive apps in the world. With our first iteration of an app, over 150,000 people have had their data shared, and there's concerns obviously around privacy. So what are we doing? What is the government doing to address this, and how can we restore faith? For a solid test and trace system, we need an app. If you agree with that, firstly, that would be a question. But also, how are we restoring faith that this government cares about privacy concerns?
Well, we care first and foremost about making sure that we deal with coronavirus. And data is absolutely critical in doing that. And so is trust in that data, which requires the appropriate sensitive use of data and the use and sharing of the data so that those who have responsibilities and can see insights in that data can help us in this enormous national effort. The challenges around developing an app that works effectively and works within the parameters that are set by some of the phone manufacturers are well documented, and we're working very carefully now with many of the global tech companies who have really put their shoulders to the wheel, and with other countries to develop this technology. It would be obviously having a piece of technology that helps with contact tracing would help, but it is not. It is not necessary to do contact tracing, because we're able to do contact tracing through all sorts of other technologies too.
And final question: when can we expect an app to be ready?
As soon as an effective one is available. But what I wasn't willing to do was put an app that we knew through rigorous testing that didn't work on half the phones of the country. I could have not done the testing and not done the rigorous piloting, and because it worked perfectly well on Android devices, we could have assumed that it would therefore work on all devices. We didn't do that. We tested it rigorously. We found some challenges, and I pay tribute to the app team who did an incredible job in bringing it to development, and are now working very closely with other companies to come up with a proposition that will work effectively.
One last question, if I may. Public First, a company owned by friends of the Prime Minister's most senior advisor with close links to the Minister of the Cabinet Office, was paid £840,000 to assess the effectiveness of government coronavirus advice. Can you explain why this was not put out to tender, as is legally required to do so?
No, tenders are not legally required when you're in an emergency situation like this. And, we have used endless capability from the private sector alongside the public sector in this crisis. And thank God we have. The public sector have been brilliant, and the armed forces have been brilliant, and the private partners who we've had working with us have been absolutely brilliant too. And the combination of public and private has been mission critical, and those who try to split people up according to whether they work for a public sector or private sector organisation and have previously made the argument that things should be purely delivered through the public sector that argument has been shown to be completely false by the response to coronavirus, which literally could not have been done were it not for our brilliant partners from the private sector.
Thank
Thank you very much indeed, sir. Mark Logan, and then Dawn Butler.
Secretary of State, thank you very much for making the time this afternoon, and also thank you for your great effort over the last few months, because I'm sure there's very few people on this today, or indeed across the country, who would want to swap places with you. So thank you for what you've been doing on the NHS, of course. My questions are centering around face masks or face coverings. And just firstly, the President of the Royal Society has called for stronger messaging around face coverings. What does the evidence say about the wearing of face coverings?
Well, the scientific evidence on face coverings has changed. This is a classic example of where more information becomes available, the science therefore improves, and we change policy as a response. And I make no apologies for doing that. The scientific evidence shows that if you're in proximity with somebody, but you're not with them all the time, then a face covering can help. If you're in a closed environment with somebody, like say a classroom, for a very long time repeatedly, then the impact of a face covering is very, very limited. But for somebody who you meet, especially if you meet a stranger intermittently and for a short to medium period of time, for instance, if you're on public transport near somebody or in a shop or in a NHS setting, then a face mask can be very helpful. And so we have we've changed policy as the science has constantly improved on face masks, and that's why we've reached the position that we have.
In the Times today, it actually featured a soon-to-be published Journal of Internal Medicine report that says that wearing face masks can reduce the amount of virus that gets into someone's system and that they don't get as badly sick. Should we have been wearing face masks from January this year?
Well, it's a very good question. The question I face as Health Secretary is what should we recommend and mandate the public to do now? I think, you know, the science. I put that in the category of scientific development in response to this virus. You know, you've got to remember that the virus didn't exist, or at least we didn't know that it existed until the end of December. You know, we first had discussions on it inside government, including Chris and I, in the first days of January, but we didn't know about it. When we first discussed it, we didn't even know whether it was a flu or a coronavirus. We knew that it was a virus that caused pneumonia. And so it's a really important point to register in considering all of the history on this, what you knew at the time. And what we knew at the time was based on that scientific advice.
And the same research suggests that I was talking about in the Times newspaper that we should go towards universal population level masking to control infections and to limit the severity of the disease. Do you agree with that approach?
I agree with the government policy on masks, if the scientific advice, taking into account all of the science, changes, then of course we are always open to that, and I think we've demonstrated that we're willing to listen to the science, be guided by the science, take into account all the other considerations and make decisions on that basis.
Yeah, I think it's fair to add.
I
think it's fair to add on this that, I mean, the science around masks has been mixed all along and continues to be so. So there are studies that show the kind of things that you've been describing. There are also other studies, and it's been one of those areas where actually science has moved most as we have moved through the virus, particularly around the area of asymptomatic transmission, which was one of the many things we didn't know at the beginning, which has become a key part of the management of the virus.
Do you think, in terms of wearing masks in the workplace, is there a possibility that advice will change, given that this report says that masks should actually be worn in the workplace?
Well, we haven't had time to consider this report alongside all of the other reports into mask wearing, and the policy is that that masks are not required in the office. And the reason and the explanation for that is because you're in the office generally with the same people repeatedly. And from a policy point of view, we have COVID secure guidelines for how to manage an office in a way that doesn't spread the virus.
And just a last couple of quick questions. I mean, roughly, how many masks do you think that we're going to require now on a weekly or indeed monthly basis across the UK?
I'm looking at my figures. I will write to you with the exact figures of how many masks were used in the last week, but it is many millions. And I get these figures given to me daily.
Committee with that, Mark?
Yeah, it's quite a big number.
You got another question, Mark?
Yes, so just the final question is, I know in the last day or two there's been reports about certain parts of the country having scaled up their production of face masks. As a government, are we thinking about having kind of resilience hubs for the production of face masks and looking into the next, the winter months and years ahead?
Yes, it's incredibly important that we as a country produce PPE, which is mission critical in a crisis like this. And I think one of the lessons of the crisis is that there's parts of UK manufacturing that in the past have been left to wither, that don't only have an economic value, but have what is essentially a national security value too, to make sure we are more reliant on things that we produce here and not totally dependent on global supply chains, which obviously came under immense stress. I mean, the performance on PPE is something where I think we as a nation can be proud of how we turned it around. It was extremely difficult for a few weeks when the demand for PPE shot up because we went from business as usual to assuming everybody had COVID within the NHS and social care and some other public services like prisons. In a matter of a couple of days, demand shot up at the same time around the world, and we had a stockpile, but the distribution of that stockpile, because it was based in a single warehouse, was very challenging. And the PPE team did a remarkable job, again working public and private sector shoulder to shoulder, to turn that situation around. We never had a national outage of PPE, although I know that there were circumstances where people didn't have the PPE that they needed. And within a few weeks, with large thanks to the leadership shown by Paul Dighton, we managed to get the situation under control.
Thank you. Does it trouble you, Secretary of State, that some other countries, many other countries, with very good records of controlling COVID, have indicated the use of face coverings for many months?
I think that we've all learned.
But have we? Why have we not learnt to emulate what others have done successfully?
Well, we do. We absolutely do, and I take that into account in the decisions, for instance, around face masks.
So as we look back, do you think we should have given the advice that we've now given earlier based on the experience of others?
Well, based on, you have to base the decisions that you take on the science that's available, which of course takes into account other people's decisions.
How come these other countries have made those decisions before us?
Well, I think that the global science on face masks has the global scientific consensus on face masks has definitely changed over the period of this pandemic.
Okay. Dawn Butler.
Thank you, Chair. I've got a number of questions for you, Secretary of State, and thank you both for making the time to attend the committee today. I just want to pick up on where you left off with my colleague Mark in regards to how proud we should be and how we've turned around the PPE. Ayinda Capital Limited secured a £252 million deal to supply PPE for us. I wonder, and it's quite a long question, but I'm going to break it up for you. I wonder how many masks were we expecting for the amount of money we were paying, £250 million. Aventus Solution Limited was awarded £18.48 million contract on the 12th of May to supply garments for biological and chemical protection to the NHS. I just wondered, because according to Company House, up until the 30th of June last year, its net asset, this company, was £322. And I just wonder how many garments have been supplied and how many garments have been ordered. And Secretary of State, the design... well, there's 3 companies. I want to put them all together that I've picked up.
Can we just establish whether the Secretary...
I'm not going to be able to answer these questions. And the reason is that the PPE buying effort was an absolutely mammoth effort. And it was conducted at extraordinary pace.
But Secretary of State, I think this is vital because you've said that we should be proud
of how we turned it around
PPE. So in order for us to be proud and to learn the lessons, I think it is really important that we try and establish what was done and why. So there was a design company, Lux Lifestyle. They were awarded £25 million to supply garments. And the pest control company, not a manufacturer, a pest control company, PestFix, was awarded a contract of more than £108 million for PPE. So I think if we are to be proud of how we turned around the PPE situation, then surely, Secretary of State, you should be able to let us know how many bits of PPE have been ordered, how many have been delivered, so that maybe we could share in that pride.
Yeah, we have now procured over 30 billion units of PPE, including 3.7 billion units of PPE contracted for through UK-based manufacturers. We've delivered over 2 billion items of PPE to over 58,000 settings. Now, that was described as by the head of the army as the biggest logistical exercise he had seen in his 30-year career. And I am absolutely going to defend my team to the last from individual complaints about individual contracts, because we needed PPE on a scale never seen before, and we absolutely contracted with people who we thought were could help us in that task. And when you take high-risk decisions at speed in order to deliver a target, then of course you do a reasonable amount of due diligence. But I will defend the people who made decisions, even if those decisions in hindsight turned out to be wrong, because of the massive task at hand. And I think in the politics of this, it's really important that we don't use perfect hindsight to try to complain about some of the civil servant decisions when they were under instruction to get PPE so that nurses and doctors and social care workers on the front line could be adequately protected.
So can I be clear that I'm not complaining about the civil servants? What I'm trying to do is get some factual information so that we can learn the lessons, because we are still expecting to have a number of people that were infected by COVID-19. And as you said, we will need many millions of PPE going forward. So it's really important if we're going to learn the lessons. Do you think, Secretary of State, that you'll be able to supply this committee with the information later on when you've got time to go through the questions that I've raised? That would be really useful. Secretary of State, Topham Gurham Limited was awarded £3 million contract and attended strategy meetings at number 10. Can you tell the committee what part of the communication strategy that they were responsible for?
No.
Okay, it's because you don't know, or?
Well, it wasn't a Department of Health responsibility. We brought in enormous amounts of talent. I mean, we brought in people right across the board, and they put their shoulder to the wheel in this crisis. Again, like never before. We brought in, if you came to the second floor of our building in the Department for Health, there you would find people who worked for Deloitte, people who worked for Amazon, people in uniform from the British Army, public health officials, scientists from Public Health England, logistical experts, and lifetime civil servants working alongside each other in a common national mission.
Yeah,
and they did an absolutely brilliant job in difficult circumstances,
Secretary,
and they're worth
I've been left
every
very little
penny.
time to ask you some questions. I mean, I agree. Some people have worked very hard and done a great job. And I'm not talking about hindsight. I'm just trying to establish.
Yeah, but you kind of are, aren't you?
I'm
So that's why I'm not going to go this down
I'm
this
trying to
route.
establish.
Some colleagues waiting to come in.
I'm trying to establish where the money went and what we got for the money, and if we in fact received value for money. Because as you've said, there's £13.8 billion budget for PP. That's a lot of money. £840,000 was awarded to the public first for focus group work. I'm assuming you're not going to be able to let me know what the focus group came of that. But, Chair, this is important because there are some questions that have been asked for people who've had the COVID-19 tests. And some of these questions, I think, are a little bit suspicious. I just wondered if these questionnaires have been commissioned by yourself, Secretary of State, or Public Health England.
I have no idea what you're talking about.
If the Secretary is not aware of them, then perhaps we can ask him to write to the committee with the details.
That would be useful. I've got one last question, Chair. Secretary of State, so it's become quite clear, taking evidence from the scientists, etc., that Parliament is quite a hotbed and has the potential of creating 650 super spreaders that then will go to each area of the country. I'm just wondering, have you had a conversation with the Leader of the House in regards to the risks?
Of course, I've spoken to the Speaker and the Leader of the House, who are responsible in their different with their different hats for the important task of keeping Parliament running in a COVID secure way. That is very much their responsibility. I've made sure that all the advice, the public health advice necessary is at their disposal to make the judgments that they make. But the only contribution I had to this debate was to insist that Parliament should stay open throughout the crisis.
Thank you very
much. And what
indeed.
mitigations did you insist?
That's a matter for the Leader of the House and the Speaker, and of course the Lord Speaker.
Can I come to Catherine Fletcher?
Thank you very much, Chair. Hello, Secretary of State. Completely different, changing topic. So, if I said Dido...
You're very faint, Catherine. I don't know whether it's your end. Is there anything you can increase the volume your end? Try now.
Does that
That's better.
improve the situation?
Yeah.
Sorry. Don't you love technology? Let me give you a list of names, Secretary of State. Dido Harding, Kate Bingham, Dr. Jenny Harries, Professor Sarah Gilbert. It's fair to say that the British have really shown themselves to be not only wonderful scientists, but wonderful female scientists as well. Would you agree?
Yes, I would. I think all the incredible women you've mentioned have played a vital part in the national response.
Look forward to them inspiring the next generation. If I select the work of one in particular that's of interest. So Professor Sarah Gilbert is receiving lots of positive press with the very exciting developments around her potential vaccine. Are we going to have a vaccine for Christmas?
Well, I'm an optimist in life, Catherine, and on the best case scenario, the answer is yes. And my job is not to second guess whether we will or not, and vaccines are an uncertain science, and we need to be cautious and we need to be careful. But I've said before that, I'll throw everything at it. We've given Sarah and her team all the possible support they could have. We are working with AstraZeneca and on the manufacture and have supported them as much as possible. And then there's the rollout, which is important as well. So we're working very hard on this, but I can't promise to play Santa.
Given the latest advice is effectively that it's safe to use and it may have a positive effect, but it doesn't appear to have in any way a deleterious effect on someone receiving it, would you consider allowing people to take it voluntarily in advance of the clinical evidence? Well,
we are encouraging people to sign up to volunteer to be part of the phase 3 trials. It's very important that's done in a controlled and scientifically valid way so that we can find out that people in the trials, whether they've had the placebo or whether they've had the vaccine, exhibit the response that we need, which is, i.e., if you have the vaccine, then you don't catch coronavirus. So people can volunteer, but the volunteering is within the structure of the clinical trial. Now, I would stress that what the phase 1 and 2 results have shown that were published yesterday is that it appears that the virus is effective in not just in the antibody response but also the T cell response, which is really important, but also that it is safe thus far. The challenge is that we'll be injecting this vaccine into millions of people, so we need to know that it's not just safe for the few thousands of people who've had it so far, but it's safe on a very big scale for the very rare reactions to it, because the proposal is what you do when you vaccinate is you put vaccine into healthy people, so you have to know that you're not going to cause more harm. And
keep it concise. I know that we need to.
So we will be very, very careful, and we'll only recommend a vaccine when we know that it's clinically safe.
Thank you, Catherine.
Last one. If anyone wants to volunteer for that, would you write to the committee and let us know how they can do so? Because the British people coming together and participating in the clinical trials has helped discover dexamethasone,
yes,
amongst others. So let's harness that brilliant capability of the NHS as well as the goodwill of the British people.
I will happily write about that, or you could look on my Twitter feed and find how you can apply to be a volunteer.
Thank you. So final
let's do both.
Final quick questions. Aaron Bell.
Yes, just to follow up on Zara Sultana's questions about the app. It's my understanding, could you confirm that no country in the world has an app that's really functioning properly, and the reason for that is that Apple, perhaps for the concerns that Zara raised, is refused to let the app work?
Well, I've made clear my views on the engagement with Apple. What I'd say is that Apple are now working very collaboratively with us in order to develop a product that will work not just here but in other places too, and we're working with some other governments around the world to try to make sure that we have an app that's interchangeable if you cross borders as well.
Because my question to Apple, I guess, would be that I've got an iPhone, I'm happy to download it, I'm happy to have the low energy Bluetooth. Would you agree that Apple should be listening to these governments around the world, and they're the ones that are getting in the way here?
I would. I can see the argument that you're making, and I want to stress how much we want to work with Apple to all be part of the solution to this problem, and that's the work that they're doing with us now and engaged on positively.
Thank you. Zara Sultana.
What are we doing to help poorer countries access that?
It's a really important point, because our approach on the vaccine is to be good global citizens and make sure that there's access as much as possible around the world. This is largely coordinated through CEPI, which is a global project to ensure access to vaccines, which we are the biggest funder in the world, because we think that it's important not just to have the science to develop a vaccine, but also to make sure that there's fair distribution according to clinical need. Now, naturally, I'm determined to ensure that there's enough vaccine for the whole UK population first and foremost. I am, after all, the UK Secretary of State for Health and Social Care. That's my job. But the point of a vaccine is that once you've got the blueprint, lots of people around the world can manufacture it, and we don't want to stand in the way of that.
Thank you. Finally, Graham Stringer.
Last question, Secretary of State, and like my colleagues, I don't envy your job. I might not agree with everything you've said, but I certainly don't envy the responsibility you've had over the last 4 or 5 months. On the 14th of July, you said to the Commons, patient identifiable data is available to local authorities when they sign a data protection agreement. I checked with the 10 authorities in Greater Manchester who'd all signed the confidentiality agreement. It wasn't true. When you responded to Philippa Whitford yesterday, you said that that information would be available to local authorities yesterday, or today, as you said. then, and I've checked, and it is. What has happened in between? Why were local public health officials not getting the information before yesterday that would have helped them deal with this epidemic?
Yeah.
Was there a sort of a territorial war going on between PHE nationally and locally? What was happening?
It's a really important question. A couple of points. Firstly, we have not been dealing with this crisis for 3 or 4 months. We've been dealing, by next week, we'll have been dealing with this crisis for 7 months in the Department for Health. I know it only came to everybody else's attention later than that, but we've been at this since the first few days of January. The question on public health data is really important. As we've been building this system, so we've also been building the data structures around it to be able to provide better data and have a better flow of data to local authorities. And I couldn't wait for the data structures to be perfect before building the capability for testing and then for contact tracing. We had to build the data structure at the same time as building the operation. And so we've absolutely tried to get the best data as much as possible through with the data protection agreements for exactly all the reasons that Ms. Sultana set out earlier, quite rightly, about the importance of trust in data. So we've constantly been trying to improve that. Now, what I said in the House last week was true, because patient identifiable data down to a postcode level, which is identifiable according to the protocols, whether you agree with that or not, and it is a matter for debate, but it is regarded by the authorities and the powers that be as patient identifiable, and that was provided. But the full individual names and addresses, as well as postcodes, were provided yesterday. And I'm glad that the 10 local authorities of upper-tier local authorities of Greater Manchester received those. I thought the question was going to be much worse, and you were going to say they didn't get it yesterday, as I promised.
That's why I checked, Secretary.
And then I was going to, I'm sure we were both delighted to find out that what I promised in the House yesterday actually happened. And but the point is, it's just part of the laying the train tracks as you're going down the track, as I described earlier, that we've been constantly trying to improve this. I believe to the bottom of my soul of the power of information and data to improve public policy decisions, and it is a difficult task. It is complicated. And we've managed to. I've dived in, and we've managed to pull it off.
Thank you. There's a one-sentence question from Dawn that we missed on languages.
Very quick, which I'm hoping is going to just invoke an easy yes from you, Secretary of State. Can we ensure that all information is provided in different languages?
Yes.
And in British Sign Language as well, going forward from today?
It's very, very important that all the public communications, not every policy document in real time can be translated into every language that's used in the UK. So I can't give that commitment because we're moving at such pace. But all of the public communications need to be appropriately translated into languages that are used in the communities in which we operate. It is incredibly important.
And British Sign Language.
And I'm very happy to look into expanding what we can do in British Sign Language as well.
Great, thank you.
Secretary of State, Sir Chris, thank you very much indeed, not just for your time before the committee today, but for your hard work over the last 7 months and more. Your work is incredibly important. It's appreciated. The committee wants you to succeed. We want to make recommendations that will commend what has been done well and to draw some lessons so that where things haven't gone well, they can be improved in future. We're very grateful for your evidence to us today. That concludes the meeting of the committee. Order.
The Boothroyd Room. Portcullis House, 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 the Boothroyd Room.